All right, this video is to do a medical patient assessment. So at this point in time, for time's sake and everything like that, we're going to assume that we've already done our scene size up, our general impression, our ABCs of the patient. So we know we have an airway, the patient's breathing, their circulatory status is good, their skin condition is fine, they have no obvious disabilities. In this particular call, Jim here is going to be have a non-specific medical emergency. We'll get into some of the other specific medical emergencies in the next videos. But he's going to be able to interact with me while I show you this stuff. So again, scene size up's done, general impression is done, our primary assessment is done. So we're going to be moving into some decision making as well as verbalizing of what comes next. So after we've done our ABCs, I would consider checking a blood sugar on this guy, and I would also figure out a transport priority. So right now, as Jim talked about a few videos ago, we need to determine whether we've got time to stay and play or whether this guy's situation is urgent and we need to get him scooped up into the ambulance and do the rest of our assessment there. So here, again, he's having a non-specific medical emergency. His ABCs are good. I don't see anything life-threatening, killer bleeds, anything that would lead me to believe that this is a load and go emergent type situation. So I think that we've got a little bit of time to stay on scene and do a little bit more assessment. So that's my transport decision, is to stay and play, so to speak, get a little bit more information, and then we'll work on getting to the ambulance after that. So at this point in time is where I would have my competent basic partner work on getting vital signs. I'm going to want him to get a blood pressure. I'm going to want him to get a pulse. I'm going to want him to get a respiratory rate. And we talked just a minute ago about a sugar. Most times the sugar is gained with the vital signs. And remember that the vital signs are what we're actually obtaining as numbers rather than in our ABCs. We're just making sure that they are in fact breathing at an adequate rate that's enough to sustain life, and it's not going to kill them right there. We're not actually getting a respiratory rate or a pulse rate with the ABCs. We just want to know if it's fast, if it's slow, if it's deep, if it's shallow, such information like that. So while my partner's getting vitals, I'm going to work on obtaining history information and illness information from my patient. There's two acronyms that we use: SAMPLE, which is signs and symptoms, allergies, medications, prior medical history, last oral intake, and events leading up. So that's going to give me an idea of what's going on with their overall health. And I'm going to also use the acronym OPQRST, which is the onset, if anything provokes it, the quality, so if he's experiencing pain or shortness of breath, what type of quality is it? Is it stabbing? Is it a dull pain? Is it an aching pain? Does it feel like compression, like somebody's sitting on their chest or anything like that? So then there's R, which is radiates. S is severity. So we want to know on a pain scale of 0 to 10, with 0 being no pain and 10 being the worst pain you've ever experienced, where does that pain rate? And then the next one is going to be time. All right, so now that we've talked about the information that we're working on gathering and the acronyms that we're going to be doing, then we'll actually go through this patient interview. Jim will be able to interact with me. Again, he has a non-specific medical problem. I'm trying to figure out what's going on. That helps me know how I can treat him. That lets me know what I may be expecting to happen. And it also gives me an idea of the potential disease process or anything like that that may be going on that will help me treat him appropriately. So I'm going to start with sample. So can you tell me what's going on today, what you're feeling, what kind of things you're experiencing?
I've got a little bit of lower back pain.
Okay. And that's it, just kind of lower back pain?
Yeah, I mean, I kind of don't feel good, but mainly I got lower back pain.
Okay. Now let me pause here for just a second and talk about the differences. So symptoms are something that the patient's experiencing but that we can't see, whereas signs are things that we are able to see. So I can't see his back pain. That would be a symptom. But if he's telling me that he's got shortness of breath and I can obviously see him struggling to breathe, then I know that that is a sign that I can see that validates kind of what he's saying. All right, so are you allergic to anything, Jim?
Penicillin.
Penicillin, okay. Do you take any daily medications?
No.
Okay. Do you have any past medical history?
I had a little asthma.
Okay. No COPD, no CHF,
No.
no
No.
history of diabetes,
No.
no other breathing problems other than asthma.
Nope.
Okay. When's the last time you've had anything to eat or drink?
I had lunch today.
Okay. About what time was that?
About 12:30.
Okay. So it's about 3:30 now, so he ate about 3 hours ago. And what were you doing when this happened today?
I was moving some boxes around.
Okay. Did it happen right away? Did you just kind of become sore after the fact?
It started hurting after.
Okay.
And I sat down.
Okay. You didn't hear anything pop or
Nope.
feel anything pull or anything? Okay. So we've got our sample, so we have a good idea about his medical history. I know that he's allergic to penicillin. For me, that doesn't affect me because we don't give anything that would aggravate that allergy, but it is something to pass on. If he were to have some sort of infection or anything like that, the doctor would want to stay away from prescribing him penicillin, or in most cases, all the derivatives of penicillin as well. So we'll move into OPQ-RST. Now, one thing that you'll notice when we talked about OPQ-RST, there's a couple things that also kind of tie back to sample. We know the events leading up. We know what happened. So we don't necessarily need to ask him the onset. If he told us already that 30 minutes ago I was moving something and my back started hurting. So we already know the onset, and really we also kind of know the time if he does admit that information to us. So while you can ask that information again, you also don't want to give the impression to the patient that you're not listening. So if you know that information again and have previously gotten that, don't bother asking again because it just sounds repetitive. So we already know onset, so I'm not going to ask this. But I'm going to move on to the rest of PQ-RST. Does anything make it better or make it worse?
Most comfortable when I sit up.
Okay. Does it radiate anywhere?
No, not really. It's
Okay.
just down in the lower back.
Okay, so for radiation, we're asking about does it travel? So we want to know, in this case, does it move up his back, down his back, depending on where he's having the back pain? And also, even more concerning potentially is, does it move down into his legs? Does it cause any numbness, tingling, or anything like that? So he's telling us it doesn't radiate anywhere. How about the quality of the pain?
What do you mean?
So can you describe what the pain feels like?
Okay, it's like a dull aching pain.
Okay. And on a scale of 0 to 10, with 0 being no pain and 10 being the worst pain you've ever had, where would you rate your back pain at?
It's probably a 5.
Okay. So he's in moderate pain, but I can also tell by how he's interacting with me and how he's rated it on the pain scale is that it's not causing any obvious respiratory distress. He's able to handle the pain fairly well. It may be something that I would consider if he was tolerating the pain much less than he is now. I may want to intercept with an advanced life support unit to consider a pain protocol and help ease that pain. But it also doesn't seem to be affecting any of his other body systems. So it seems to be an isolated incident of back pain that seems to be directly related to his activities of moving boxes earlier. So that concludes the medical patient assessment. The only other thing we would consider in this case is a physical exam of some sort. We're either going to want to do a full head-to-toe physical exam, as similar to what was demonstrated on the trauma patient video, or we're going to do a focused physical exam. A lot of that's also going to depend on the mental state or altered mental state of your patient. If they're altered, they can't really tell you what's going on, and you suspect that if you were to do a full head-to-toe, you might find something else, you're probably going to want to do that. Whereas in this case, he's alert. There doesn't seem to be anything else going on. There doesn't seem to be any other body systems involved. It seems to be isolated back pain, so in that particular case, I'm probably going to expose his back, lift the back of his shirt up a little bit, probably take a look to see if I see anything. I'm still looking for decap BTLS, and I'm going to palpate that and just do a focused physical exam to see if there's anything when I go hands-on in the area that he's experiencing pain, if I can find something that would help me come to a conclusion or treat him better.